So my name is Margarita Garcia. I work for Social Services Giant. I'm the Director of Admissions and Outreach of the intake component. And what our program does, we pretty much evaluate and assess individual needs for substance abusers. So we may see anywhere from 25 to 30 new cases per day coming into our programs. And really it's assessing their need, what they do, what types of drugs they do, how much do they do, and what level of care they need to go into. The programs that I work for now have about 1,000 beds. So we have around 12 different residential treatment programs around New York State. And my job is to pretty much keep utilization at each of the sites. And it's pretty much a struggle to, do a lot of the assessments because a lot of the clients that come in are in a crisis. So you have to kind of evaluate what crisis they're going into and pretty much work with the community-based organizations to look at other resources, because sometimes we don't have all the resources in this particular agency. So you might have to send someone to detox, someone to rehab. So our team is really skilled at, identifying those needs for each individuals and then, referring them out to whatever other services that we particularly don't provide. I think we admit anywhere from 40 to 55 people a week. It depends on the need. And you might say, wow, you see 25, 30 cases a day, but you only admit 40 and 55 people a week. But, because people come in needing other various levels of care, we really have to kind of pretty nitpick to see who will be appropriate for our services, right? Some people might not do well in a therapeutic community or in a long-term residential program, or they may have social supports at home and they might do better in an outpatient program. So we have to, there's a lot of people that we do service that don't actually make it through our doors. I speak to a lot of families every day. I mean, I'm surprised my phone's not ringing, but I think I speak to more families in need, wanting to get help for their loved ones. And it's a challenge, right? Because especially for residential treatment, you gotta want it. You gotta want the help. It's a completely voluntary program. I mean, of course, we do see certain folk that are mandated. And I guess they want the program because they don't want the jail time, right? So it's a great benefit for them. But for the families that don't have a mandate, it's a little bit more challenging to try to get someone to be engaged. And for those families, I kind of give them an overview of our programs. I always kind of harp on telling them, listen, they gotta want this, right? Probably one of the best things to do for those cases is, one, families need to get that help. They need that support. So they need to find a group of sorts, right? There's tons of them around New York State, and I actually, for the program that I work for, they actually have an association, a family association, where the families get to talk about, any challenges they're having at home, how to engage their family members to want treatment. Usually it's a lot of tough love helps, saying no when they're asking you for money, giving them the resources, maybe them doing a lot of the research and giving them those resources. But usually the big things that helps, the better thing that helps is the tough love, the not enabling them, right? Because a lot of the addicts, they do get really codependent on their families, and unbeknownst to the family member, giving them that $10 every day, or paying their rent, it actually enables the addictive behaviors. It helps them continue to do what they do. So for those families out there, I advise them to look up their resources in their community, really educate their loved ones about what resources are available to them, and recovery coaches. I mean, there's a new big thing that's coming out in the field. It's recovery coaches. There's a lot of recovery coaching centers that are opening up throughout New York State. And, these are centers that someone who is kind of ambivalent about treatment, they can go to, and they don't have to be completely clean, right? I advise them not to go there high, because they're not going to get the, full gamut of what they do. But for those that are kind of ambivalent about treatment, they can actually learn about recovery, see what recovery feels like, right? Because in these centers where they do a lot of socialization for the clients, they teach them how to navigate their community centers or other organizations that, deliver some treatment-based services, and then just kind of stand back and help them. There's maybe some intervention services that they might kind of tap into. I know there's a lot of coaching in the community. I'm not sure what cost derivatives may come from that. But for particularly a lot of non-for-profit organizations like ours, we don't make financial cost a requirement, right? Because especially a lot of addicts, they don't have anything. They've lost everything. So, putting a financial barrier to coming into treatment is I think it's kind of discriminatory, right? And almost inhumane, because people are really, really dying out there. And really, that's one of my challenges, is getting people in here before they die. So generally in the United States, there's anywhere from 20 to 40 million people who have a substance use disorder. From those, 2 million seek services. The stark data from that is that even in New York State, we have had a 46% increase in overdose from last year. From 2010, we have seen 154% increase in overdoses. So it just keeps getting higher and higher and higher and higher. And it really just speaks the need to have places, treatment centers such as ours, to kind of meet the need out there. I mean, it's incredible, and mostly is the opiate users. We see a lot of opiate addicted individuals coming into treatment. I think probably about 50% almost of the people that we see coming in have opiate addictions. Like I said before, I've had cases, and even I would say about a couple of months ago, I had a case where client left detox. I had no beds. So he continued to call in for a bed. And I finally had a bed opened. I called him up. I said, hey, we're getting you in. And on the date of admission, I get a phone call that he passed away. And the guy was only 26 years old. So, for me, it's more of, although this is work, right? It's a passion of mine to help the community. I feel like I'm filling a purpose, right? Trying to bring people in, because that's my job. I bring them in, and then I send them to different various other treatment programs. But just getting that one individual in, it can make the whole difference. And then to get to see them on the other end, right? It's so heartening to see when someone finally gets it, when they gain a little bit of color in their face, their families are coming around, right? It's something that you rarely, because the recidivist rate just coming into treatment, right? It's pretty high. I've seen clients come here 4, 5, 6 times. And, Some of them make it, some of them don't. I think right now our completion rate can be anywhere from 40 to 43%, which is high considering the nation average, I believe, was about 30% or so. Not really sure about that percentage, but I'll look it up and I'll send it to you. But yeah, so, I think that the work that we do is so important. It's so important, and federal funding definitely needs to kind of open up to open up more treatment centers. And like I said, especially for the opiate addicted, because, beds, residential treatment and bed availability for the opiate users who are on medication-assisted therapies is very hard to come by. So I think that definitely needs to be targeted. But in a bigger sense, I think that we do great work. Now, the state has actually begun to change treatment a little bit more. And it's looking at addiction as a medical issue. So one of the biggest challenges before was drug addiction was thought to be a behavioral issue. Something wrong with the individual and how they behave. And, through studies and a lot of research, they found that it's actually it's a biology issue. It's a chemical imbalance in the brain. And we're starting to treat it as such, right? So now we do a plethora of assessments to gauge where a person is at. So we do something called the MINI, where we assess mental health. We do a DAST and a MATH, which assesses the drug use, whether they have significant drug use or minimal substance abuse. We look at treatment motivation, which is really important, right? If we're delivering a service, how motivated is this person to get to want to be here? We do something called an AWARE, which measures the probability of the relapse, whether someone is going to relapse, and the probability of them relapsing within the next 2 months. We do brief craving scales, because that's huge, right? The craving for the drugs, the tolerance, the withdrawal. We have scales that kind of measures those type of diagnostics, so that we can then better prepare a service plan for the individual. And I think it's helpful when you treat it as when you gauge for medical necessity rather than a behavioral thing, right? Because if you treat a substance user, and let's say that they get medication-assisted therapy, which in this case will be methadone or Suboxone, right, or buprenorphine. A lot of people have a lot of stigma against those medications. But you won't have a stigma for someone who is diabetic and is on insulin. So treating substance abuse as a disease and, putting forth medical staff around to kind of, help that individual from a medical perspective is going to help, I feel, is going to help so much destigmatize the medication-assisted therapies and, put a lot more resources in helping somebody recover, like you would a diabetic. I'll go a step further. One of the things that happened in our programs was, if you relapse, you gotta go. And this was just a common thread throughout therapeutic communities and residential care. If you use substances, you gotta go. But if you eat a donut and your insulin and your diabetes resurges, your doctor's not gonna say, "I'm not treating you no more," right? What's the logic behind that? So I think that where the field is going in terms of the treatment and the resources that they're putting into residential treatment care is definitely gonna help assuage this epidemic, because that's exactly what it is. It's an epidemic, and it's getting bigger and bigger, and if we don't do something new, I'm afraid that we won't have much left of our community.